again for joining us for our MDA Engage community webinar today on dental health and neuromuscular disease. My name is Marissa Lozano, and I'm the Director of Community Education here at MDA. We are thrilled to have you join us for this important and educational webinar. The webinar is part of our larger MDA Engage community programs, which focus on bringing the neuromuscular disease community together around education and resources. Please be sure to visit the MDA Engage section on mda.org for updates on upcoming virtual education programs. We are recording today's event, and we will be posting it to our website, mda.org, for on-demand viewing to ensure those that were not able to join us live today are able to access this information. Please know that all lines have been muted. We will be having a Q&A, a question and answer session at the end of the webinar. So please be sure to utilize the Q&A or the chat window to type in your questions. It's right at the bottom of your screen on the right-hand side. You'll just click on it and enter questions. You don't need to wait. As questions come up along the presentation, feel free to send those in and we'll address them all at the end. Before we begin, though, I'd like to say a special thank you to our speaker today, Dr. Ronak Parikh, whom you will meet shortly. For over 70 years, MDA has led the way in accelerating research, advancing care, and advocating for the support of our families. MDA's mission is to empower people living with muscular dystrophy, ALS, and related neuromuscular diseases to live longer, more independent lives. We break our mission into these four pillars: care, through our national network of MDA care centers. We provide multidisciplinary care across the U.S. and support individuals and families from day one of their journey. Champion, through our advocacy and education efforts, we empower families with information and resources. Catalyst, through our investments in research, we are furthering advancements in treatment discoveries. And lastly, community, through programs like summer camp, community education, such as this program, and our community events. We are helping individuals and families build supportive connections and relationships. If you haven't done so already, we invite you to join the MDA community by registering with us. Please see the link in the chat for how to go about registering with us. And with that, let's review the objectives for today's webinar. We're going to talk through the impact that neuromuscular disease might have on dental health, provide some practical ways to care for your dental health, and discuss how to work with your dentist to meet your needs. Now it's my privilege to introduce today's speaker, Dr. Ronak Parikh. Dr. Parikh's lifelong love for helping others enjoy healthy lives originally led him to study cardiology. But with a change of heart in his career path, it wasn't long after he shadowed a local dentist that he realized a natural passion for crafting smiles and changing lives in a way that felt most meaningful to him. For Dr. Parikh, his first experience holding a dental drill could best be likened to Harry Potter holding his wand for the first time and discovering he was a wizard. Dr. Parikh attended the University of South Florida, where he achieved his bachelor's degree in biomedical science and went on to earn his master's degree. Went on to earn his master's degree in biomedical science from Barry University. He then graduated as a doctor of medicine and dentistry at Roseman's University College of Dental Medicine. Endlessly dedicated to providing the highest level of care for his community, he's an active member of the American Dental Association, American Academy of Clear Aligners, Academy of General Dentistry, and a fellow of the International Congress of Oral Implantologists. Dr. Parikh first became involved with MDA in his youth when he volunteered as a camp counselor for our summer camp program. And his experiences at MDA summer camp led to a lifelong commitment to the neuromuscular disease community. We are so excited to welcome him here today. And Dr. Parikh, I'll turn the time over to you.
Thank you. I appreciate it. It's always a little weird hearing all your accomplishments kind of read out, but I'm glad to be here. Just like Marissa said, my background, actually, I started volunteering in muscular dystrophy when I was about 16 years old, was I think the first time. It was the first time I'd ever volunteered. I actually even found one of the original pictures I had with at the camp So I actually included in the presentation. We'll get to that. But yeah, today's lecture is going to be about neuromuscular disease and dental implications. There are so many different complications and different things that we need to be incorporating into care. So one of those big things that we're going to talk about is a little bit about muscular dystrophy. There's some things about myasthenia gravis. I think I have some for ALS and a few other diseases and disorders. So it's not going to be completely thorough in every single neuromuscular disorder, but there are a lot of similarities between them. So we want to make sure we cover as much as we can. So we'll get right to it. Let's see. There we go. Yeah, so a little bit about me. This is actually that picture we were just talking about. Let's see.
Dr. Parikh, I'm sorry. It doesn't look like your slides are showing. You might have to just reshare. Sorry.
Okay, let's try that. How about now?
There you go. Just put it in slideshow mode and you are good to go.
Perfect. Does that work?
Yep.
Good. Okay. There we go. So back to it. I got my start in MDA, working in MDA summer camps. I work as a private practice doctor, and obviously I'm not a specialist in neuromuscular disorders, but I do have some experience dealing with those conditions and some of the dental implications that can go along with it. The limitations that I would say for the most part are there are smaller sample size, and there's a lot more research that needs to be done figuring out what are the dental implications and what can we expect and how can we manage complications and treat patients so that they can live long and healthy lives with their teeth. So there's a lot of crossover between the disorders. One of the big things that we notice is there's a loss of motor skills. I think almost every single neuromuscular disorder has some form of that. Some of the motor skills that you'll experience are hand gestures, hand movement, dexterity to be able to manage, brush, floss, and all of those things in between. Facial control is another big part. Using certain things like water flossers become more difficult when you can't control your lips and tongue to help control the flow of fluids. And then obviously the increased growth or expansion of tongues, muscles, and bones are definitely all the big things that we want to talk about. And again, this is obviously not everything, but some of the big highlights. So we're going to start with Duchenne's, and that'll be kind of the big part. And the big two changes that we notice, especially for the oral environment, are the musculature and the tooth changes. So for musculature, we're noticing a high level of tongue enlargement. This really is characteristic because now tissue that we're seeing in the tongue has a high level of adipose tissue that's replacing muscular tissue. And that expansion actually leads to a lot of difficulty. One, because there's an increase in tongue expansion, you'll notice difficulty chewing, swallowing, speaking, and then also it creates expansion of the teeth because the tongue actually influences where your teeth are going. So because the tongue is expanding, you're going to notice that lower jaw and lower teeth alignment is going to be completely out of characteristic. And so that affects some of the classic characteristics of anterior protrusion, which is basically the lower jawbone is pushing out further than would be expected, especially for a certain age group. And those limitations, they can create limited mouth opening, difficulty chewing, speaking, kind of all of those things. Some techniques that we've seen that really work, stretching jaws daily, trying to use some muscle exercises, and even as simple as chewing gum has been shown through quite a bit of research that it can increase bite force and kind of maintain things where we want to be. So definitely something we want to make sure we can add on to. So changes in the dentition we're noticing is that there's a reduction in bite force because the teeth are becoming more misaligned as the tongue enlarges. We can see a decrease in bite force, and by decreasing the amount of force that you can put down, you're not actually able to chew food as effectively as you normally would expect. So now you're getting larger pieces of food that are actually going to areas where we don't want them to be. And if you're not completely chewing them, there's a high risk for airway issues, and ultimately there's also some diet issues because if you're not able to chew your food completely, you're not getting the high level of nutrition from that food. So bite issues are definitely a big part of the misalignment, and it increases as the tongue expands over time. So we actually expect them to get worse once the progression of the disease increases. So posterior crossbite is basically the misalignment of the back teeth, and that's really, again, characteristic by that tongue expansion. And then class 3 bites are basically where the lower jaw expands further than the upper jaw. In the classic dentition, you expect the top teeth to actually go over the bottom teeth. And in class 3 bites, you're expecting actually the lower jaw to go further out, which makes chewing really difficult because now you don't have that interaction in the front teeth to be able to rip off a piece of food. Orthodontic treatment is sometimes indicated, but it's difficult because the source of the misalignment is because of the tongue expansion. And so without necessarily resolving that, orthodontic treatment isn't really going to work. And I'm going to show you guys a case of that as well. So yeah, risk for abnormal breathing is also a pretty big part to it. So sometimes some patients who are in further progression to the disease might need general anesthesia just to maintain and make it easier for them. This is a rare occurrence. It's not common for every patient to need that. It just depends on what stage. But I would definitely say speaking to your doctor about figuring out what percent or progress of the disease you're in and where we think we can manage that. DMD patients do have poor hygiene, more cavities, inflammation, plaque buildup, and mouth breathing is a very common consequence of that as well. And that also leads to periodontal disease and delayed and eruption of permanent teeth. All of those are really characteristic because we're seeing abnormal growth patterns. We're seeing a difficulty in managing the oral hygiene. Brushing becomes more difficult without a caregiver. Flossing becomes more difficult. So all of those complications increase as the progression increases. And so our number one goal is prevention, because preventing a problem is a lot easier than solving the problem. And that's a big part of why we want to make sure annual visits are really important, because if you're going any less than 2 times a year, you're going to have more difficulty finding and catching those problems before they're problems. And so that brings me to my next point, which is that some patients may benefit from an increased number of cleanings. Traditionally, everyone is kind of under that part that you should go twice a year to the dentist and get 2 cleanings. But for some patients who have mobility issues or dexterity issues, going 3 to 4 times a year may be really helpful, because yeah, it does increase the number of cleanings, but it decreases the number of cavities and the number of teeth that are going to be damaged from poor oral hygiene. And then one last thing also, managing wisdom tooth risk. I did get a couple questions about that as well. Wisdom teeth don't necessarily always have to be removed, but in patients that do have poor oral hygiene or difficulty with oral hygiene, it may be wise to get them taken out early on to prevent a problem later on. And that's also difficult because as the progression of the disease increases, it becomes more difficult to reach back there to be able to brush, and also makes it difficult for the doctor. And sometimes those patients do have to be sedated. So that's also something you have to weigh over time. One of the big risks, obviously, are difficulty swallowing and blockage. Because we're not able to chew food completely and we have larger pieces of food that we're swallowing, it increases the likelihood of GERD or other kind of gastrointestinal issues. And that inability of the muscle to contract increases the ability or the inability of swallowing those big pieces of food. So if we're not able to digest them and we're not able to chew them, that increases the likelihood that we could have an airway issue. And that's really the biggest part. So some of the big things that we want to make sure we're managing is that we're always trying to drink water after a meal, because it will decrease the amount of food particles that we have, but also decrease the pH balance, because every time we eat, we increase the pH balance, which is what causes the cavity development. And that increased pH allows more acids to build up, and that's what breaks down teeth. So this is a great example of a case. This patient underwent a few procedures at the University of Minnesota. This is a pretty classic example of what we'd see. This patient, I believe, was about 23 or 24 years old. I have to double check that. But one of the big complaints he had was that he felt like he could not bite down completely. And that's absolutely true. It made it almost impossible for him to eat certain foods. And most of the foods he was eating at one point were blended. And that was definitely a quality of life issue, because he really wasn't enjoying eating. He also really didn't enjoy his smile, and that was another big part of what we wanted to solve, or what the team wanted to solve. So you can see there's definitely some food buildup over time, especially in this area. You can see on the right side, there's almost no food buildup, but on the left side, it's because on the right side, he was not chewing at all. And on the left side, that's pretty much the only area that he was able to chew. So those are big things we want to make sure we address as well. So for this patient, what they ended up having to do, because there was so much expansion of the tongue, more than what would be expected for his age group, they actually performed a procedure where they reduced the size of the tongue. Now, this is a relatively rare indication. This is not common for all DMD patients, but this can happen if the expansion of the tongue is so much that it's affecting airway issues. Patients don't feel like they can breathe, they can't swallow, speech is impaired, and then obviously chewing and eating certain foods is also impaired. For this patient, he's unable to close down completely. The tongue reduction was a big part of the surgical plan, and then obviously removing wisdom teeth. Because of the airway issues and the expectation that once that section of the tongue is removed, there would be some breathing difficulties. Tracheostomy was performed as well to make sure that his airway was maintained during the entire part. And then he did have to spend a month in a care facility undergoing that treatment. But after just the surgery in 7 months, you can see there's a pretty drastic difference in terms of how he's biting. He's almost able to completely bite down on that left side. And on this right side, he's able to bite down much more than he was before. There's also a big difference in terms of his appearance. He's able to smile more, and he's able to bite into those areas. We do notice that some of the hygiene issues, so that was definitely addressed as well, and that's something that was focused on before the next stage. The next stage was really just correcting the misalignment and in trying to improve some of those bite characteristics. So he actually went through 21 months of braces. This is not abnormal. A lot of patients do have to go through braces for anywhere from a year to 2 years. In his case, there was a little bit more of a complication. It took a little longer, and there were some different approaches that are involved that are abnormal for what we'd expect for the majority of orthodontic cases. Like I said, it did take 21 months. So this is the final result after the end of the braces. You can see the alignment has improved drastically. His smile has improved. He also notes that he definitely can bite more, he can eat, and that's not really an indication that's causing him an issue. So all in all, a really successful procedure. Again, not common for every single DMD patient, but definitely an option for those patients who are noticing that they're having tongue mobility issues, they're having speech pattern and chewing disorders or issues with that part as well. And you can see obviously the size of the tongue. After the procedure, the tongue has completely healed. There's nothing that makes it abnormal. It didn't affect his speech patterns, or he didn't have any real big issues with that part. And this was kind of his last statement on that. When he was interviewed, one of the big parts that he mentioned was he really was fortunate enough that he felt like it was worth it, and he didn't regret it at all, which is always a tough thing, especially after a pretty long procedure. I mean, he was in treatment for about 28 months, 28 to 30 months, I think is what the range was. So that was definitely a long period of time to be going through that part, but the end result was great, and it also had a huge change on his quality of life. Even his mother was pretty happy with that, and she was glad that they managed any of the issues in the hospital setting, because it really would increase the risk if he was doing this at home. Going on to our next, myasthenia gravis. That's the tough part. There's a sporadic progression of the disease, and that makes it difficult to manage certain complications. So starting out with the understanding that the progression is going to happen, but not knowing when it's going to happen, we want to make sure we're managing and treating as many things as we can before progression takes a hold and makes it difficult to treat those things. Another common thing is weakness of the tongue, facial musculature, and then obviously swallowing and chewing difficulty, pretty similar to what we see in DMD. Difficulty breathing is another big part to it as well. Patients can be seen in a dental practice, but it really depends on where they are. One of the big parts of the dental practice are there aren't any real management cases for how we would manage someone who has difficulty breathing. If someone has an airway issue, Most doctors are trained in ALS, so they know how to manage that, and EMS services can obviously be called. We want to make sure that we're not putting patients in a position that could be a possibility. And so for those patients who are more moderately or extremely affected with their airway issues, that's definitely something you want to see in a hospital setting. For more mild patients, being seen in a general practice can be done. And you don't have to see a specialist for that part, as long as you're able to make sure that you're discussing any of the advancement or progression and any of the complications that you're unaware of or that you're concerned about. And also the doctor knows to look for those things as well. One of the big parts are definitely oral infections or stress can create an increase in symptoms. So one of the big things we want to make sure for those patients, we want to have shorter appointments in the morning, just because any medication you're going to take is going to have a higher effect because you're probably going to be taking it in the morning. So it's going to reduce the risk of a crisis. Also decreasing the amount of water-based tools that we use. If you're on a patient that has breathing disease or breathing disorders, using a lot of water-based tools can almost be like waterboarding them. So it's definitely something we want to try and minimize. And there are always, non-water-based tools that we can use that just increases the treatment time, and it can sometimes increase the discomfort. So those are also things that we can manage. Some of the big things are, one, helping the patient stay open by using mouth props, also known as a bite block. Great because it helps support the jaw, gives the doctor clearance to be able to see and make sure that they're managing the area, and then everyone is kind of supported in that spot. Also, we want to make sure that we're seating patients, not all the way back, because again, that creates that effect of them having difficulty breathing and also having a lot of water placed in those areas. So keeping them semi-upright is definitely very helpful. And then minimizing the use of dental lights by using darker glasses and trying to keep it away from their eyes, also really helpful because we want to make sure we reduce the risk of a crisis. One of the big questions that I actually got the day before was there any risks for certain types of anesthetic? There are risks for certain types of anesthetic. One of the big parts are if there's an ester-based anesthetic, that can create an issue. So we want to use an amide-based medication, and that I actually have a list of some of the ones that have contraindications and some of the ones that are very widely used and have shown to be really low risk. So lidocaine is probably the most commonly used dental anesthetic. In the past, doctors used Novocaine, and patients complained of issues with Novocaine. But now, we've moved pretty far away from Novocaine, and I would say relatively few doctors, if any, really use Novocaine to this day. More of what we're seeing is lidocaine, which is a completely different derivative of that. Lidocaine, Pivocaine, and bupivacaine are the three big that are used, and then obviously articaine would be our other big parts. Some of the other medications are things that doctors may prescribe you for certain procedures. So all of those are great examples of things that you can use, but definitely with caution. And obviously, with some are contraindicated. So some of those are antibiotics, or some of those are those anesthetics that we want to use. Moving on, we're going to go to ALS. So there's definitely an increase in metallic uptake dysregulation. And so newer research is showing that some patients can be diagnosed with ALS well before they actually have any symptoms. They're finding that there's certain markers in teeth that actually can show that. So this is relatively small samples, so I don't think I think they're working on a larger study, but it's very eye-opening because there's always dental implications that we don't even realize. There is newer research that's showing that patients who are pregnant have a higher rate of miscarriage because they have periodontal disease, or periodontal disease can actually increase the probability of you having heart disease. So there's these not necessarily well understood interactions, but now, with further research, that's becoming a big part. So this study, was relatively small, but still kind of interesting because that's something that you wouldn't necessarily expect, especially for a neuromuscular disorder. So I think that's where it's kind of important and hopeful, because now new research is being done in that part, and now dentistry is kind of pushing that part as well. So again, another great thing to kind of look out for. Same thing with ALS and some of the other neuromuscular diseases. making sure to not push the chair back too far, minimizing the use of water, and then also using an oral evacuation device. And I'll kind of explain that a little later on. But those are great ways to help patients manage and then prevent them from feeling that overwhelming feeling that they're not getting enough oxygen. Myotonic dystrophy. So patients with myotonic dystrophy have a lower finger force. That really correlates to decreased levels in oral hygiene. Basically, with a lower finger force, you're having difficulty controlling your muscles, which makes it difficult to control a toothbrush. So then as progression increases, you're needing someone else or another caretaker to manage those things. Research is showing that they have fewer teeth, higher caries risk, and more likely to build up plaque, but there's no changes in alveolar bone. So you're not having the same kind of expansion or teeth movement issues that you're seeing in DMD patients. Lower salivary secretions and slower sugar clearance rates also increase the risk of cavities. Basically, all of your saliva has certain antibodies that decrease the level of bacteria that you have in your oral environment. But if you're not producing as much saliva, you're more likely to get cavities because you don't have those antibodies. So patients with dry mouth are really prone to cavities for this very reason. Then you add in the part where there's a slower sugar clearance rate. It means that bacteria are able to breed faster, grow quicker, and damage more of the environment in less time because we're not able to clear sugar and the bacteria from that part. They're also showing that children have a higher rate of complications, especially boys, which I didn't include there, but that is another part of that study as well. And it's really just more of compliance. So more frequent cleanings and more frequent exams are definitely an important part because we want to catch those problems before they're problems. And that's really the name of the game. If we can solve an issue before it starts hurting you, or if it starts, causing issues in sensitivity, that's definitely beneficial, and that's something that as every doctor would make that decision once they see a patient. It's hard to make, a generalization. How often can someone come in? For our patients, we usually say anywhere from 2 to 3 times a year is a good starting point. And then we can always increase the number of times just to make sure that an issue isn't occurring and making sure that anything that, the patient or the caretaker isn't able to get to, we can obviously get to. But the longer an area is being underserved or the longer the area is kind of having an issue, the more likely a long-term problem is going to develop. Progressive facial and muscle weakness are common, especially with malocclusion in myotonic dystrophy patients as well. So pretty similar to what you're seeing in DMD patients as well. Basically, bites are off, and if your bite is off, you're not able to chew as much. Adding in the lower finger force, now you're not able to clean as much, and it kind of snowballs from there. So those are all things that we definitely want to make sure we're managing as soon as we can. The best form of dentistry is prevention, solving the problem before it's a problem. I think I say that all the time to patients, and I say to my staff as well, because it's the best solution to the old way of thinking, which was let's wait for a problem to occur. I hear from patients and parents and pretty much everyone, I'll wait until it hurts. Well, that's actually the worst possible idea. It's kind of like saying, let's wait until I have a heart attack to start exercising and eating healthy. That's not really how you want to solve the problem. You don't want to wait until there's a hole in your ceiling and water is flooding your house to start taking care of those things. I'm trying to find as many analogies as I can to make that work. But that's definitely something that you want to solve ahead of time, not when it starts hurting. So some of the big forms that we want to make sure, using a fluoride-based toothpaste, cleaning in between teeth with floss, really important. Using electric toothbrushes, also very helpful. Sometimes there is some mobility issues, so we'll kind of go through some ways to manage that as well. There are some medicated fluoride washes and some that are non-medicated and non-fluoridated. That also do a good job of minimizing and decreasing that decay or gum disease. And there are certain tools like water picks that also help really get food out of. Think of water picks kind of like a pressure washer for your mouth. It does a good job of getting into areas that maybe would be hard to reach with floss or maybe hard to reach with a brush. And then again, getting to the recall visits, You don't want to wait too long. You want to make sure you're getting to those things sooner rather than later. A small cavity in a routine cleaning beats, having to extract a tooth, having an abscess or an infection, and then ultimately having to remove that area. Avoiding emergencies is really important because from the doctor's side, we really want to make sure we have everything we need to manage any kind of risk and that we're prepared so that if we have a patient that has those mobility issues or has a neuromuscular disorder, we have everything we need. But in an emergency setting, sometimes we don't have everything we need. We are not able to plan ahead. And that makes everyone's lives more difficult, and it makes the experience more difficult. And that's the last thing we want to do for our patients. So making sure we have those materials and treatments is really the most important part. Some of the big daily hygiene things that we want to talk about. Brushing twice a day, very important. Sometimes you can actually increase that amount. Brushing twice a day is kind of based on research that's for patients that have, I would say, good to great oral hygiene. If your oral hygiene is poor, you want to kind of catch up and prevent those problems. So brushing 3 times a day wouldn't be abnormal or out of the ordinary. You can do more than twice a day, but you don't want to be doing it 6 times a day. And so there's a healthy balance that you want to do. And that's really something, again, that you want to talk with your doctor because every case is really different. Replacing your toothbrush every 3 to 4 months, really important because ultimately bacteria builds up when you're not using your toothbrush. As soon as you leave it on the counter, water is sitting into that brush for a while, and that is building up bacteria. And then you're putting toothpaste on it, which decreases the bacteria count, but then you're putting it in your mouth, and so you're introducing those bacteria right back into the area. So you want to minimize that, and every 3 to 4 months is a good kind of starting point. Flossing, again, it's not something you only have to do once a day, but at least once a day is really great because there are parts that your brush is never going to get to. And in between your teeth is probably one of the greatest areas that you're going to get cavities. I would say almost 60% of patients experiencing a cavity have it in between those teeth because it's so susceptible. It's the area your brush can't get to, and it's the area where it's wedged between 2 points between the teeth, which is where bacteria have a really easy time developing. So for patients who are in dentures, changes in weight loss can also increase dentures kind of not fitting as well. So making sure to manage those complications. And that really just becomes either having a reline with your denture or having new dentures made periodically. Usually about 5 years is what insurance will cover, but sometimes it could be less, it could be more. Some of the other tools that we're going to talk about, I'm going to show some pictures, are toothpaste dispenser, dental wipes, water flossers, electric toothbrushes, floss holders, tongue scrapers, oral rinses, suction devices, suction toothbrushes, and some of the other therapists who can help with those kind of adaptive equipment. And here are some good tips or tricks. Really a lot easier to brush when you're sitting down than when you're standing, especially when standing is really physically exerting for some patients. So sitting down makes it a lot easier. Lying down makes it easier. You just want to make sure you're propping that patient up, or that the caretaker is propping up that person so that we're not letting a lot of toothpaste kind of slide back. If you're having trouble holding a brush, wrapping the brush with foam increases the grip. So we recommend you can do it as anything as simple as bubble wrap or packing foam, anything that'll increase the handle size, which will make it easier for someone to grip. And then using an electric toothbrush, which is really going to do most of the work. I think of an electric toothbrush kind of like driving a car versus a manual toothbrush is kind of like riding a bike. They're both going to get you there, but one's going to get you there with a lot less work and a lot faster. So for all of our patients, we recommend electric toothbrushes because it really helps solve and decrease how much motion you have to make and how much work you have to really do for that part. And then for dry mouth patients, there are formulated mouthwashes and some that are just generally, like I said, for fluoridated, or some that are just focused on reducing the bacteria count. So these are the 2 toothbrushes I recommend. Both companies make better models, but these are, I think, the entry-level models. They both have timers to make sure patients are brushing for 2 minutes at a time, and they Generally, I believe these two models do have sensors that tell you when you're pressing too hard. That's another big part or misconception. Some patients feel the harder I brush or the more pressure I apply, the cleaner the teeth are going to be. It's actually the exact opposite. You're actually doing more damage than you would expect. Teeth are not like, the tiles on your floor. The harder you scrub, your tiles are going to be cleaner. But with teeth, they're an organic matter. So the harder you scrub, the more minerals you're scraping away. And the more minerals you scrape away, the more likely that area is going to develop a cavity. So definitely something you want to make sure that you're avoiding in that part. These are my two favorite floss brands. Glide is great for really tight spots. I've heard from a lot of patients that flossing hurts. Flossing is kind of like working out. It only hurts because you're not doing it. If you're not flossing, it's more likely to hurt because you're not flossing. There's a lot of inflammation. There's a lot of food that are trapped in those areas, and that makes it difficult to get back in there. So every time you go in there, the inflammation increases. So the only way to get through it is you actually have to get through it. And that first 2 weeks, I think, is really, really important because that's where you're going to feel the most discomfort. And then after that, you're going to feel a lot less. And it's going to make things a lot easier on that part as well. Both of these brands are great. The Glide Floss is really great because it can get into tight spots. It's really thin and very durable. And then the Cocoa Floss flavor is great for patients that maybe have an enhanced gag reflex. It comes in a lot of different flavors. Fresh coconut. I think there's a mango and orange flavor. So for some patients who have that difficulty with some of the older style mint flosses or wax flosses, this is a good way to kind of solve that problem. So for some patients, obviously mobility is an issue. So using an assisted flosser like this really does a good job of making sure that someone can get back there and floss. It's hard to wrap your fingers around and go into someone else's mouth and floss. This is a really great way and a relatively inexpensive way to make sure that we're at least flossing once a day and getting into some of those areas. So definitely a good option, and you can find it anywhere from Walmart to Amazon. Water flossers are kind of that, depends on who you ask. Some doctors will really love them, some really hate them. I think the vast majority of dentists are kind of in between on that part. I like them because it's a good intro and it gets patients who necessarily aren't flossing to at least do something. I think it's a good example, of a good starting point. And there are two major brands, one that's cordless and one that's wired. The big difference between the two is the cordless version has a smaller reservoir, so you're more likely going to need to refill it once or even twice during one session of using it. Versus the larger tank size, you're going to have a better approach. It's going to be stronger. You're not going to have to refill it, but the negatives are it's wired, so it can be difficult to move around. I feel for our patients who are in wheelchairs and they have a caretaker, it's easier actually for the wired version because it weighs less, it's smaller, and it's easier to angle in those tight to reach areas. So that's what we recommend. But either one does a good job. They both have their pros and cons. So kind of a trial and error for some patients. But I usually start to recommend the wired version first. And if you're feeling that you're up to it or you think you can take the challenge, you can always use the smaller one. One of the best toothpaste that I recommend and that I use every day is Sensodyne. For me, I have really sensitive teeth, and one of the things that we notice for patients with neuromuscular disorders or anyone who has lower levels of hygiene, we're noticing that there's a high rate of sensitivity, and it's from any of the foods that we're eating, any kind of sodas, juices, candies, cakes, all the sugary foods, but also it can come from chips. So anything like that that's going to have that high level of acidity or increase that anaerobic environment, we want to try and manage that by decreasing the sensitivity for those patients. And one of the best ways I found Pro Enamel to work is that I actually apply it to all the areas and surfaces of my teeth, and then I let it sit for about 2 minutes, and then I brush like I normally would. The longer exposure time does a really good job of making sure that sensitivities decrease. And I would say for almost every patient that we recommend it for, in about 2 weeks' time, they notice a pretty large decrease in that sensitivity. So definitely something to help for those patients who are having sensitivity. This is, I think, the big question. I think I received a few questions about this as well. Officially, all dentists who are a part of the ADA and every toothpaste that receives an ADA seal of approval has to have fluoride. That's the requirement. They will never recommend a toothpaste that doesn't have fluoride. And I still recommend fluoride. I think it does a really good job. There are some newer approaches to toothpaste that are still being relatively researched, and there are some promising alternatives to fluoride, but I don't think that we're necessarily there yet. But I think it's looking very positive along that route, and I'm interested to see where the research goes in the next few years. Those alternatives are nanohydroxyapatide based toothpaste. Basically, your tooth is made up of a couple of core minerals. Calcium, potassium, and sodium are kind of the big three. Any one of those minerals decreases when we eat something acidic like soda, or we eat something sugary, or potato chips. That acid breakdown of the tooth decreases the mineralization of the tooth structure. And once you lose a lot of mineralization in a specific spot, that's where a cavity occurs. So in an area where you're not necessarily brushing or food is developing and kind of pooling in that spot is prone to getting cavities because of the acid content. So the core value of these hydroxyapatide-based toothpaste are to remineralize those areas. Now, Sensodyne or Pro Enamel, which was the toothpaste I just recommended, that does a great job of remineralizing. That uses the fluoride version to remineralize those areas. A hydroxyapatide base is going to use those other minerals to help remineralize the tooth structure. And this study showed that it was I think it was a relatively small sample size. I can't remember right off the top of my head. But it did show that it had very comparable levels to fluoride-based toothpaste in terms of minimizing the demineralization and increasing the likelihood of remineralization. So I'm excited to see some more studies on that, because I think that'll be a really big game changer for some patients who don't like fluoride or have some negative thoughts on fluoride. And also some of the traditional manufacturers of toothpaste are now developing some newer approaches. So all of it is a good thing in the long run. These are the three big mouthwashes that we recommend. Act is great for those patients with dry mouth. It's an alcohol-free version versus the other two that I'm showing right now do have alcohol in it. For alcohol-free mouthwashes, they do have a higher number of chemicals in there to compensate for the alcohol loss. Those chemicals can sometimes cause an imbalance. Some patients have reported that they notice like a dry film that does occur over those areas. So that's definitely something to be cognizant of, because you could be one of those patients that maybe doesn't react as well. And then talking to your doctor about what's the best approach of what type of oral environment. Some patients don't even realize they have dry mouth. So definitely something we want to make sure we're focusing on. The other two do have alcohol. Listerine in the green bottle is a pretty classic, iconic one. It does a good job of reducing the bacteria in the oral environment, versus the Listerine in the purple bottle does a good job of remineralizing, and it has 6 benefits. It helps prevent cavity. It restores the mineral matrix. It strengthens teeth. It kills any of the periodontal disease or bad breath. It does a lot of those things that are really important, but the most important part is it's reducing the bacteria, which is the most important thing. Tongue scrapers, I've seen a lot of different versions. I've seen the big metal ones that people scrape against their tongue. That's not really a great idea. It is effective because it is going to scrape your tongue. The negative part is if you use it for a long period of time and you're scraping against that part of the tongue, you can basically create a callus on your tongue, or you can change the type of tissue on your tongue. Both of those things are really not great, because if you're creating a callus on your tongue, you're going to get kind of that bulging formation there, which is going to change the way that you eat, chew, and talk. And also changing the type of tissue on your tongue changes your taste buds, changes the way your tongue feels, and it kind of makes that uncomfortable part. This is a great example because it's going to prevent you from using too much force, and it's also going to help neutralize and remove that bacterial layer. So definitely something that I recommend at least once or twice a day is a great example, or a great idea, because you want to reduce the oral bacterial count, and this is a good way to do it. This is a relatively new idea. So it's called an oral suction device or oral suction toothbrush. basically you're going to brush, or a caretaker is going to help a patient go through and they're going to brush. It's also going to suction any large pieces of food that maybe a patient isn't able to swallow or wasn't able to get out of those areas. It does a really good job. The research on it is relatively new, so I really didn't include it. But I have had patients who've had really great experiences with this. The negative part is they are very expensive. I think the lowest price that I saw was about $350, and it can go up to $700. So pretty expensive, but there are some good examples. All you really have to do is Google, suction toothbrush, and I think I saw, I think 3 or 4 examples right off the bat. So a good example, but maybe not practical for every patient. Everyone would have to choose what's going to be in their budget and what they think is really effective for them at that stage. This, I think, is a really practical and really easy approach. Sometimes with patients who have mobility issues and dexterity issues, even taking the toothpaste out can be difficult. This makes it really easy. All you have to really do is push into that spot and it's going to dispense. And they're relatively cost effective. I think these were $10 or $13 on Amazon. So a really easy approach to solving that problem. Dental wipes are another good example. Sometimes, I think I showed that picture earlier with that patient who went through the surgery and the orthodontic treatment. There's a lot of pieces of food that you don't realize that are that far back until someone's in there. So obviously, sometimes you're not going to be really close to a bathroom, so you can brush. This is a good way to help remove plaque and bacteria, and I found it really great for anywhere from children to even adults who just need to help kind of remove the bacteria and the amount of food pieces that we're seeing in those areas, especially for those patients who are mobility and dexterity challenged. A caretaker can go through it with relative ease and kind of remove and reduce the amount of food pieces in those areas. This is what I was talking about a little earlier. This is an oral evacuation device. This is called a dry shield. This is pretty common. Not every dentist has this, but you can find dentists who do have it. You can always ask a dentist, do you have this? It actually does 2 things at once. The first is it's actually going to keep the mouth open, so reducing the amount of force and the amount of muscles that you need to help keep your jaw open and stabilized. And then it's also going to remove any of the fluid that's building up in the back. This helps the patient because now they're not feeling like they're drowning. Sometimes even though there are assistants in the room that are there suctioning, water still pools in the back. They can't really reach every single area. This reaches pretty much every single area and minimizes the amount of fluid that you're going to build up in the back portion, while also stabilizing a patient's jaw so that they're not having those issues. Yeah, and so those are the big things that I kind of wanted to note on. I think I got like a 50 or 75 questions last night, so I was up pretty late kind of trying to answer as many as I could. I guess we'll just hop right into it and I'll start answering some questions. Feel free to send in some questions if you don't feel like I've covered it through this part, but we'll start off with the biggest part. How often should you clean your teeth with MS? How often should a cleaning be done? This is a great question. I think this works for DMD patients, MS patients, myasthenia gravis patients, ALS patients, pretty much anybody who has a mobility issue or notices that there's a big change to the oral environment. Brushing 2 to 3 times a day, very beneficial. And I would say getting cleanings 3 to 4 times a year is also beneficial as well, because the number of times you're getting a cleaning decreases the likelihood that something large is going to develop. So those are great examples, and you want to be brushing, again, twice a day, flossing at least once a day, and using mouthwash and tongue scraping once or twice a day as well. Let's see. Oh, so any devices to help with severe OSA, as my son is not keen on the Trilogy mask. That's a very common complaint. Most, patients with sleep apnea, especially those masks, are pretty loud, obtrusive. If you're a side sleeper, it makes it really difficult. They have there's actually pretty well-known research that it works really well, but almost very few patients can live using it all the time. So they've developed some newer mandibular protrusion devices, which basically kind of advance your jaw. So you're kind of pushing a little forward, and it forces your jaw to be a little bit more open, so you're able to breathe in. That's been some of the best research and more likely usable. And that really, you have to go through someone called a sleep dentist. You can Google it, but sleep dentists are usually associated with sleep doctors, and usually the two have a pair. They kind of work in tandem. So definitely something to Google for your area, because that's a great way to find someone for that. Another good example is how to treat someone who has a tongue thrust. There are a lot of different devices. Some of them are scarier, kind of obtrusive looking. This is probably the mildest form. Basically, it's something that makes it difficult for your tongue to kind of roll in and advance into those front teeth areas. Decreasing likely, you're going to create that anterior open bite, because with your tongue is strong enough, it's one of the strongest muscles in your body, you can actually push your teeth completely out of alignment. And we know that because that's exactly how DMD patients and some of the other neuromuscular disease patients are having those misalignments with their teeth. See. So yeah, same thing. How do we let a doctor know who want to assist with a case like this? Really being upfront about the medications, being upfront about what challenges you're experiencing, what you think you need help with, or what we think we need to have a game plan for the future, and then kind of managing complications and the progression and seeing what we need to take care of before it's too late. Also really important. Trismus is a really common complication after a dental procedure for almost every person in the groups that we discussed and more. Massaging your jaw, very common, but that doesn't really work for every patient. So we recommend, heat therapy does a good job, because it's going to help kind of stretch that jaw out and also kind of reduce the tension. Using soft foods for a few days or even a week to 2 weeks after a procedure does a good job. And then sometimes medication is really just the next best bet. Using acetaminophen or Tylenol, ibuprofen, and then even sometimes using a muscle relaxer would be a great way to help minimize that tendon or that muscle issue. This happens for patients who have neuromuscular disorders and those who don't. So it's across the board, but these approaches have been the best routes for solving that problem. I did get a lot of medications about how to find a medical professional or a dentist who are going to be able to manage this part. That is a really tough question. I've seen some in community-based clinics, Good Samaritan programs, church-based groups, but there's no really uniformed approach for solving this problem. And I think that's a big part of what dentistry needs to advance in the future. So that's definitely something to be on the lookout for. But yeah, that is one of the hardest things. I found that if there was a certain type of procedure that I can't solve, usually I'll call a local hospital and see if they have a dentist on staff, and seeing what his qualifications or her qualifications are and what they feel comfortable managing. That seems to be the best way. And usually their website will say, what they're capable for. So in my area, there's one doctor pretty much everyone knows to refer those cases to, because that's all he does. He works out of the hospital, I would say, half the time, and that's really what he's geared towards managing. So that's really, I would say, the best way to kind of manage that part as well. Another question, and I received a few questions for this as well. Are there any research, really profound research for metal fillings and causing certain types of diseases or disorders? Truthfully, there isn't anything really strong or conclusive. There's always research that's going on, but the tough part is always evaluating what research and what a research result means. It's easy to find research to prove anything that you want, as long as you have a small sample size. So a good example is you can have one group of patients who, two patients, one has polymyelitis, the other one also has polymyelitis. You have one person remove all of their metal fillings, and you have the other person remove all their metal fillings. One person got better, one person didn't. Now you can easily show that there's a 50% success rate with removing metal fillings. Was that really the metal fillings that was the cause, or maybe it was something else? Maybe it was their medication. So it's proving without a doubt that this is really the source of the benefit, without jumping to it as the most difficult task in research. And that's definitely the big part that everyone's kind of gearing towards. But yeah, there isn't any conclusive research showing that there's something wrong with it. My personal view is I even still have a metal filling, but I don't perform metal fillings anymore because there are a lot of complications that can occur because metal fillings are prone to fracturing, breakages, and they generally deteriorate. So I'm not a big fan of them. So I do recommend going outside of the amalgam fillings and kind of going towards those resin-based fillings because that's really the best approach. You tend to actually make the filling smaller, so you're not needing as much room, so you're creating less damage to the tooth, and it's much easier to replace down the road versus the metal fillings. They pretty much, because they're so large, to remove them, you have to really create a lot of damage to get them out. So definitely a good way to kind of avoid that. Can a ventilator affect my dental health? Absolutely. Ventilators actually have a specific type of issue that occurs, which is ventilator-associated pneumonia. Basically, bacteria is pooling in your oral environment. That bacteria is pooling and you're breathing it, and you're getting assistance through the ventilator, and that ventilator can also pool that bacteria, basically creating a reservoir for bacteria to build up, and it can cause that level of pneumonia. It's not very common, but it does happen. So reducing the bacterial count in the oral environment, very important. How different medications affect dental health? That's a really tricky question because every type of medication has a different complication. Some of the biggest things that we notice is that there are certain medications that'll increase dry mouth, and there are certain medications that'll increase grinding. Those, I think, are the two biggest characteristics. And then the third being some medications will create vomiting, which will create acid erosion, which increases the likelihood that there could be long-term dental damage. Those three are the big medication-induced dental effects. Considerations when discussing braces. Some of the big considerations are what's causing us to have misalignment and needing, braces. So for that patient that we discussed that case earlier, that patient had an enlarged tongue. So even if you did braces and you didn't address the enlarged tongue, as soon as you took the braces off, the whole thing would fall apart. So addressing the tongue was the most vital part because then once you manage what's causing the problem, you'd be able to solve it long term. The use of corticosteroids and certain other medications can make you more predisposed to gum and periodontal disease. It's really important in making sure you're seeing your dentist regularly because those are things that we're mapping and trending. I know some patients always hear, when they're seeing a dental hygienist, they're calling out those random numbers. Those measurements are what really let us know if there's a change that's occurring. So that's why coming back frequently makes it easier to track and solve problems, because when you're waiting 2-3 years, the measurements aren't going to be really accurate, and then we're kind of have to restart that baseline. This was probably one of the best questions that I saw. Does Pompe disease affect TMJ? Not directly, but inadvertently, yes. In patients with, Pompe disease, jaw fatigue is very common. It's almost one of the guarantees that you will have some level of jaw fatigue. And then every time you're chewing foods, you're more likely to create that fatigue. And so that decrease in calories decreases the muscle's capability of maintaining. And so that breakdown of muscles increases the likelihood of developing some form of TMJ or TMD disorder. So yeah, in a way, it does kind of affect it. That's really where making sure we're getting the right type of nutrition and maintaining, and then having a caretaker who's going to manage those things is really the effects or non-effects of Novocaine. Does it take longer to process in our bodies? That's a really good question. There's probably a lot of informal research on it, but I would say anesthetic processing is really dependent on the person. There are some people who need more anesthesia than others, and sometimes it can be dependent on size. Sometimes it's really just your body's ability to process and break down. So there's no really rhyme or reason. It's really dependent on you, and having an upfront conversation with your doctor saying, hey, I need more anesthesia than normal is a great. I have patients who tell me all the time, yeah, I felt like I always need more. Great. If you feel like you need more, let's just start off with using a little bit more than we normally would. Because the last thing I want to have is you be in the middle of a procedure going, oh man, I'm really feeling it. That's not the kind of experience that you want or that we want for you as well. If you're having difficulty, one of the best ways, kind of that dental flosser that we mentioned earlier on, would be a great way to solve that problem. That really is helpful for someone who's assisting, or if someone is having some dexterity issues but still wants to attempt it themselves, this is a good way to do that. Is a dental specialist really required for patients with neuromuscular disorders? Not necessarily. It just really depends on the progress. As the progression increases and the complications increase, and there's breathing issues, then it becomes more likely that you may need to see a specialist or a hospital-based dentist to manage those complications. But it really depends on the comfort level of your doctor, and that's definitely something that, if you have concerns about that, absolutely call the doctor and ask them. Usually their staff will know, and if they don't know, they'll ask the doctor and go, yeah, I'm trained to know how to do this, and some that'll go, no, I'm just not comfortable with it, or I haven't really done it before. This was another question that I received. Finding a doctor with specific chairs is really difficult. This is a good example of the type of chair that you'd have, but I would say it's tough because it does make it difficult to find someone who has that exact part. Some newer dental chairs do have a function where the patient doesn't necessarily have to get out of their chair. They can kind of lean their head back, and they're able to reciprocate or support their neck and head for that part. But that is a difficult part, is finding the exact chair so that they don't have to get out of their operated device. How do you locate a dentist who has experience with neuromuscular patients? Really calling the local doctors, local hospitals has been the best route, even for our area. Trying to find someone is tough, especially with different disorders and different issues and mobility issues. So that's been the best route for us. How does a prescription of Fosamax affect dental health? Really great question. Fosamax is an oral bisphosphonate, so essentially it regulates the breakdown and buildup of bone. Fosamax is usually prescribed in patients with low bone density, so osteopenia, osteoporosis patients are probably the most likely. The common complication is, once you take this medication, it increases the likelihood that if you do have a dental issue, it's going to cause something called osteoradionecrosis, which is basically, a really negative consequence of taking a tooth out. So making sure that all of your dental issues are addressed prior to going on that medication is really important. The oral medication isn't too bad. You can work around that. The IV medication really is difficult, and usually you have to be off the medication for however long your doctor prescribes. Sometimes it can be 6 months to a year before you can have any dental work done. For patients with anxiety issues, dental sedation is another great option. It's a great way to make sure patients don't have anxiety while in the dental chair, and it also makes for a smoother appointment and a smoother experience for the patient. How often are Lefort surgeries with maxillary distractions? They're not very common. That's really more about a facial imbalance or a facial disproportion. So it's easier on younger patients because their healing time is going to be lower, and there is a slight increase in complications as you get older. Let's see, how to prevent something kind of going back or kind of aspirating when you're in a dental care. Using a throw pack is a really great example. Some doctors use small pieces of foam that they'll place in the back of your throat to prevent anything from falling down and then you swallowing it. Sometimes you use gauze, and sometimes you can use the oral evacuation device that I showed earlier. So those are all great ways to prevent that. Using activated charcoal toothpaste kind of has a negative effect because it strips the mineral layer for that tooth structure. So not a great way. You want to make sure you're using a remineralizing toothpaste, because most of what we do during the day eating wise is going to demineralize. So adding on top of that, using a charcoal toothpaste is going to demineralize it even further. So something we're going to manage in terms of complications. We did talk a little bit about the Pompe's disease and the accumulation. Burning mouth syndrome and CMT. I wasn't able to find any real clear link on that. Burning mouth syndrome can occur for a number of different reasons. Cold foods is a good example. Lots of fluids, avoiding alcohol and smoking are great examples. And then there's something called magic mouthwash that your dentist can prescribe. That does a really good job for some of our burning mouth patients because it's basically coating in a special type of medicated mouthwash that's going to minimize the pain that some patients are feeling. Difficulty opening wide enough. Same thing, you want to make sure we're using a bite block. Wisdom tooth removal, that's really a case-by-case basis. Some patients need it, some don't, but we want to make sure if we're even thinking we need it, we want to do it when they're younger versus waiting until they're older because the complication rate is higher and management is much more difficult. CMT, is it common for people with CMT to have dental decay or issues? Yes and no. Any type of decay or issues is really more from the oral hygiene, not necessarily the disease state causing something directly. It's more of an indirect part to it. Are there common structural or differences since birth for muscular dystrophy? Some congenital changes are noticeable. It's really more that you're noticing it through the progression of the disease. That's when you're more likely to kind of see those things and becoming more obvious. But yes, there is a possibility of some really starting very early on. Nerve damage after a gum, into the gum or any kind of procedure. Anytime you're getting local anesthesia or getting a shot for a dental procedure, it shouldn't really be numb after a few hours. If it's lasting longer than 24 hours, there is a chance that it could just be a little bit, it could be inflammation in that area. It's definitely something you want to talk to your doctor because numbness after the day of the procedure is very unlikely unless your doctor is prescribing you something very different. Almost every patient should not be numb after 24 hours of a procedure. Let's see. Working with an orthodontist and speech pathologist can definitely improve conditions. Sometimes you can need surgical intervention for those speech impediments. Sedation dentistry with children is always kind of a tricky part. Unfortunately, with children, there's always an increased risk elevated for having complications with sedation. So I'm not really a big fan of that because if we can manage it without it, it's a good thing to avoid that risk. But sometimes we just have to. So being really careful and making sure that we're only crossing that bridge when we need to is really important. For most patients, especially children, you can use nitrous, which is very common, has been used for many years and has been shown to be very safe to manage a lot of the anxiety and fear that kids may be feeling. And then is there an association between brittle teeth, low calcium, and Alzheimer's and dementia? No direct link, but not consuming enough calcium can definitely create that issue. So it's hard to know what was really the cause because you could not have been taking enough calcium your entire life and then develop Alzheimer's. Was it Alzheimer's that caused the calcium or was it you not taking enough calcium? It's hard to know what the real cause for something is, especially something that spans an entire lifetime. But so far, there's no research to show any direct or clear link. Yeah, so that is everything I've got. I think there were quite a few questions. Let me see.
Yeah, I can help you go through them. Thank you so much, Dr. Parikh. I mean, I think you covered a lot of these, but we'll pull out a few that maybe we can revisit. Friedreich's ataxia. How do you deal with mental dysfunction plus high-level quad with unintelligible speech and low lung capacity?
Yeah, that's a good question. That is definitely something that would need to be hospital-based. That's also something that we are challenged with as well. Compliance in a patient is the most important part. If you can't really keep them open or have them prevent them from closing down intermittently, it makes it almost impossible to manage, see, and solve problems. So sedating those patients in a hospital setting is probably going to be our best bet, especially if we have a lung issue. We also want to make sure we're doing that as well. But again, that's a case-by-case basis.
Another question, neuromuscular disease patients who are on daily steroid regimen have adrenal insufficiency. Is nitrous really okay? Our endocrinologist did mention that we should opt for local or general.
So you can use nitrous. Nitrous is really just nitrous oxide, and we invariably, every time you breathe in, there is a certain amount of nitrous and oxygen in the air you breathe. Again, it's a case-by-case basis, but there hasn't been any research that I've seen that can cause an issue. General anesthesia actually presents generally a more an increased risk, but I would say the lowest risk and the most effective method is local anesthesia. If we can numb a patient to a point where they're not feeling anything, they generally don't need any other medications. All of those things are really more to help with the patient's anxiety, not reduce the pain or discomfort that they're feeling during a procedure.
I know you talked a little bit about different types of dental chairs and for individuals who are in a wheelchair and it's hard to transfer. Do you have any other recommendations? I know you said calling to see if they have a different type of dental chair, but any tips on just how to transfer even, or ways to make patients more comfortable?
Yeah, there are ways to kind of manage that part, but there's nothing really standard. And dental offices and especially dental rooms are relatively small, so there's nothing really that can be easy to do that. I have seen some approaches where they have a bar that's hanging that the patient can kind of grip onto, and that'll help reduce the amount of weight that you're transferring or how much is being directed in that part. But there really isn't a great way to do that. For our patients who have mobility issues and are in a operated chair, we will sometimes just lean them back and we'll perform the procedure while they're still in their motor chair. So there is some value to that as well, because the dental chair just really helps with visualization and angulation, but you can perform certain procedures just in the comfort of your normal chair.
That's actually what I was going to ask is, have you ever just had them stay in their wheelchair and be able to perform the procedures? So
half the time I do both.
Gotcha. Okay. A couple questions about floss. Does floss string hurt teeth?
No. Does it cause discomfort? Yes. Is it going to cause damage to your tooth? No. But like anything, if you do it enough and you do it the wrong way, you can cause it. I think I have one anecdotal case where I had a patient who flossed like this on one single tooth, and she would just run it back and forth. And she did that for 20 years, and she basically created a saw motion, and she kind of cut into the tooth. But I mean, she was creating so much friction in that spot, she could have started a fire at that point. So, you don't want to do that much force. You really want to be more about scooping and kind of pulling out. And then another thing is sometimes, food gets trapped, and when you pop your floss in, you almost push the food deeper down. So sometimes you can create a small knot in your floss, pop it in, and then pull it through the side, and that'll help kind of pull some of the food out that maybe you wouldn't be able to get out normally.
Are the brush-like flosses effective?
That's a really good question. Not really. They're not bad, don't get me wrong. Anything is better than nothing. But the brush-like flosses are kind of, I think a good way to describe it is shampoo, body wash, and conditioner all in one. That you can put everything together, but you give something up. And that giving up is the tough part, because you invariably miss something. And if you're missing something in your environment, you're going to increase the chances of getting a cavity or having a problem. So I'm not a big fan of things that combine things unless they're going to do a really good job. So yeah, not a big fan of those.
Makes sense. Do people with muscular dystrophy have more TMJ issues than the normal population?
I think that there's definitely a high rate. I don't know necessarily if it's more than the general population, because the general population has a pretty high rate of it as well. In the last few years of wearing masks and the stress of the pandemic, I've seen a lot of patients have increased TMJ issues and some of those problems. So I think everyone is really prone to it, but I think with DMD patients, there's definitely a concern for it because we're losing a lot of that musculature and we're having that uncontrolled motion, and we're more likely or more prone to mouth breathing, so you're keeping your mouth open for longer periods of time. So I think it's definitely something that can contribute to an increase.
Let's see, a couple more questions here. An individual said that their son is 7 years old and has CMD. He has his adult front tooth coming at a 90-degree angle and another adult tooth on top of it coming in the same way. He has an appointment in 2 weeks, then another consult in January. What would you suggest in this case?
Yeah, so eruption, in kind of the wrong place, especially when you have two teeth kind of coming in almost relatively the same spot. That is a really difficult complication, and I'm sure that's probably the reason why they have so many consults. It's difficult because in a child that young, how much can you really do? Where do we expect development to go? And any changes we make now could be undone from development later on. That's a tough one, especially if we don't know how much bone levels in those areas. It's more likely that one of two things will happen. Either by some miracle, it'll resolve itself, which is unlikely but possible. Sometimes you have to go through an orthodontic treatment to help move certain teeth out of the way to prevent that kind of car crash scenario between two teeth. And then the third being sometimes you may have to remove a tooth with the understanding at least you'll save the other one versus losing both of them. So it's a tough thing, especially in a child so young. Again, without x-rays, it's really hard to say for sure exactly what it is, but those are the big three things that come to mind. But, I would really want to see an x-ray before I really for sure say something on that. Again, at 90-degree angle, that's tough because you really kind of have to move that into the correct position or else the tooth is really doing very, very little.
In addition to having FSHD muscular dystrophy, I have a prolapsed mitral valve. I used to take an antibiotic before dental visits, but now they say it's not necessary. Any thoughts on that?
Yeah, so the research is showing that overall, most people are over medicated on antibiotics. Antibiotic resistance has been in the news quite a bit in recent years. It's becoming more common, and actually, there's a lot of disorders and issues when you're using antibiotics too often. One of the big parts is C. difficile, Clostridium difficile, which is basically you use an antibiotic so often that you actually destroy the good gut bacteria that you have, and then the negative bacteria or the bad bacteria that you have in your stomach that you may be ingesting actually are able to overtake the good bacteria, and that can cause a whole host of issues. So the research has shown that actually did nothing to help patients avoid an infection. It actually increased the likelihood that they were going to get an infection. So that's why most doctors have kind of moved away from it. There are certain conditions that do need it, but those are really relatively rare. Another one that does happen a lot is especially after certain types of joint surgeries. Doctors were prescribing it a lot, and dentists were using it as well. But the research has been pretty profound that it's not absolutely essential. Some orthopedic doctors are still using it, and that is up to them. It's every doctor's discretion. But the research on it from the dental side has been pretty profound that it does very little. So
interesting. I did not know that. Another question here. For my son, our dentist is planning to remove baby tooth. After that, the orthodontist is going to do braces to align his tooth. He has Duchenne. They're interested in knowing what numbing method is good for Duchenne, and also it looks like there was a follow-up question about tongue hypertrophy, excuse me, and just kind of anything suggesting or recommendations for him.
Let's do the first question. So with eruption especially, that's actually the normal way that we manage that as well. Sometimes you're going to have baby teeth that are kind of in the way, and if they're preventing permanent teeth from coming into the right spot, sometimes we have to kind of accelerate the shedding of those baby teeth. So some local anesthesia that pretty much works on every single patient, especially for a young patient. We only use lidocaine because that's the only one that's been researched to be effective in children and be safe for children. It's the same medication that we would use if for some reason there was a pregnant patient, because it has the lowest rate or lowest risk for causing an issue. So lidocaine is probably the best for that local anesthesia procedure. And then the second question was for tongue hypertrophy. Right? Now I'm doing it too. For tongue enlargements that occur. There's really nothing that we can do without surgical intervention to manage that growth. It's really being, can we avoid surgery? Are things, is there so much crowding because of the expansion of the tongue that now we're seeing, the misalignment of the teeth, and that is open bites? And then is surgery an option or worth it for us at a certain point? So those are all important things that, again, you'd have to talk to your doctor and kind of get an opinion for. But usually for someone so young, that's not something that I would really. That's something, later on that I would see as an option. Because ultimately the progression is going to continue. So if you do it too early, the benefits won't be really materialized because eventually the expansion will still continue. So you want to have a good point where it makes sense surgery-wise and risk-wise to go through that part.
Great point. Another question, follow-up on trismus, which, and correct me if I'm wrong, you said trismus is like a small mouth opening. Is that, if you could define that for us?
It's really just the difficulty with closing in that part. So basically it's like a muscle strain that happens. It happens really commonly after dental procedures, but for patients with neuromuscular disorders, especially if they have musculature issues to begin with, then you factor in staying open for an hour, it almost guarantees that you may have that part. So yeah, managing that part is really important. Was there another part to that question? Sorry.
Yeah, with that, this individual said that their trismus is chronic. It's a problem during cleanings, not necessarily post-procedure, but during. So any tips for handling that, like if they need to have wisdom teeth removed, how to manage that?
So that may be a good example of if a patient is sedated, they won't necessarily have that problem. That may be a great way to do it. Sometimes, using that oral evacuation device or a mouth prop does a good job. But if they're not having the complication after the procedure, taking frequent breaks would be the best bet. Even though wisdom teeth do feel like some patients feel like that's going to take a long time. It doesn't necessarily take a long time, especially if you're seeing a trained professional like an oral surgeon who performs that procedure very regularly. They're able to usually do it in a less time than you would think. So yeah, I would say taking frequent breaks, maybe breaking it down into 10-minute slots makes it a lot easier.
All right. I think those are all the questions. I have one last one for you, Dr. Parikh. What would you recommend to folks that are here with us today on how to find a dentist or how to talk to the dentist about your needs? Any tips on like what to look for, what questions to ask?
Yeah, definitely. Finding someone who works with children and works with adults is great because sometimes you'll find a doctor who's working specifically with pediatrics, but eventually, the child will get older and now you're transitioning out. So finding someone who's going to be there for the entire journey is also really helpful because they know from day one what was going on, what's happening, and how things are progressing versus trying to find someone necessarily later on. With that being said, you should sometimes see a pediatric dentist. Just because there are some things that a general dentist is not going to be able to do, especially if there's a complication. Having a pediatric dentist who's familiar with it is definitely helpful. But starting in the pediatrics and then transitioning and kind of going between the two is really helpful. So we have patients who see myself once a year and they see the pediatric dentist once a year. So that way we're getting both opinions. And then anytime I see something that's off or they see something that's off, we kind of communicate so that way you're getting two sets of eyes with one problem.
Makes sense. Well, Dr. Parikh, thank you. We sincerely appreciate your time, your expertise, and your continued support of the neuromuscular disease community. We would love to hear the audience's comments about this webinar. So if you have a smartphone, you can open up your camera and point it at the QR code on the screen, and a survey will pop up. If you don't have a survey, after the end of this webinar, you'll get a pop-up to take a survey. Again, we'd love your feedback. It's very important to us. If anybody has any questions after this webinar, please feel free to email them to us at mdaengage@mdausa.org. We'll follow up with you. And if you are new to MDA through this webinar, please sign up with us, join our community. The link to do so is in the chat. It'll help you stay up to date on the latest information and education opportunities, and also just help you connect. So with that, this concludes today's MDA Engage webinar on dental health and neuromuscular disease. Thank you very much for attending, and we hope that you have a great rest of the day.